duration, which then allows us to differentiate these disorders. And it's important to differentiate these disorders because their treatments differ and they're highly disabling. So let's start off talking about cluster headache and defining it. The International Classification of Headache Disorders classification criteria outlines a phenotype very well. The attacks in cluster headache are severe. They're unilateral, strictly unilateral, but can be side variable from attack to attack. The pain is in the first and the second division generally, in the orbital, supraorbital, and the temporal region. The attacks generally last from anywhere between 15 minutes and 3 hours, though they can be a bit longer at times. And the attack frequency is usually 1 to 3 a day, but ranges anywhere between 3 a week to as many as 8 daily. By definition, you need to have at least one of the cranial autonomic symptoms, and any of conjunctival injection, lacrimation, ptosis, meiosis, either edema, nasal blockage, or rhinorrhea, as well as facial or forehead sweating count. However, if you do not have one of these, then either a sense of restlessness or agitation during the headache is also allowed. And that is pretty much outlining the phenotype that these people tend to be very restless and agitated during the attack because they've got such excruciating pain. Now, just to put a bit of more meat on the bone and compare it to the main differential diagnosis, which is the other trigeminal autonomic cephalalgias. The attack frequency in paroxysmal hemicrania is generally higher, and they can have as many as 40 a day. It's quite usual for them to have 5 or more a day. And in Sung-Tensuna, it can easily go into the hundreds, whereas hemicrania continues a continuous pain by definition. The attack duration in paroxysmal hemicrania is between 2 and 30 minutes, so it's shorter than cluster headache, but does overlap with it. Whereas Sung-Tensuna tend to be less than 10 minutes generally, so differentiating cluster headache from Sung-Tensuna is generally not a problem. The pain quality doesn't help us because they're all very similar, albeit that Sung-Tensuna tend to be in neuralgia form more so than anything else. They're all very severe or can be very severe. But the one thing that does stand out about them is that, at least with cluster headache, a significant proportion of these patients have either circadian periodicity, with the attacks occurring at about the same time, or a circannual periodicity, with the bouts occurring at about the same time. That circadian periodicity drops as you go across the groups. By definition, they all have to have significant cranial autonomic symptoms. But one thing to be mindful about is that migrainous symptoms are also quite common. Symptoms such as nausea, vomiting, photophobia, phonophobia tend to be quite common amongst these patients as well. Restlessness occurs in about 90% of people with cluster headache, occurs in a huge proportion of patients with paroxysmal hemicrania and hemicrania continua, 70 to 80%, but not so common in Sung-Tensuna, where it's only about 30%. While we tend to think of aura as something that goes with migraine, be mindful that aura can also occur with all of these, and there are rare cases described with as many as 14% of the patients with cluster headaches having the typical migrainous aura. In terms of triggers, alcohol tends to be a prominent trigger for cluster headache, whereas cutaneous touch tends to be a trigger for Sung-Tensuna. The majority of the patients who have got cluster headache have the episodic variant, whereby they get long remission periods in between, with only 10% being chronic. And as you go across the group, that proportion of chronic patients increases. In terms of epidemiology, cluster headache occurs in 1 in 1,000, with all the others being very rare. Cluster headache has a male predominance, and in the main occurs in people between the ages of 20 and 40, though there's a very wide range of presentation. So that's the phenotype. Why do patients get cluster headache? And one of the underlying etiological factors is genetics. In 6 monozygotic twins, there was 100% concordance. When you look at first-degree relatives, then it occurs 13 to 46 times more than you would expect it to by chance. And when you look at family histories, it's reported to occur in between 2 and 20% of families. So we did this meta-analysis to pin down that figure, because between 2 and 20 seems to be quite a large figure. And what we reported in this meta-analysis we published recently is that about 6.3% of the patients will have a positive family history. And that positive family history seems to be higher in females, not fully understood why, but there was a high degree of heterogeneity in the estimate that we got. So this supports the view that there must be a genetic cause for cluster headache. And this led us to doing a genome-wide association study. So there were 2 studies published at the same time in Annals of Neurology just earlier this year. There was one study which was the UK-based study, where a lot of people, including Pfizer, were involved. And we did that in collaboration with our Swedish colleagues. And the second study was by the Dutch, and they did it in collaboration with the Norwegians. Again, both studies are fairly large, well-controlled, and we got exactly the same hits. There were 4 risk loci that were identified for cluster headache, very firmly putting cluster headache on a genetic etiological basis. Now, we've done some downstream analysis. This is work that is still in progress. And of the 5 candidate genes that we have, all of them are expressed in the human brain, and they are largely neuronal, though there's also an endothelial one amongst them. And when we've looked at the pathways that are enriched, what we find is that these genes are likely to be important for regulation of glial cell function and regulation of gliogenesis. And at least some of the pathways also involve immune cells and cell adhesion. Which of these are going to turn out to be important, we're not quite sure about, but this is work in progress, and look out for this as time goes on. Now, what is going on in the brains of people with cluster headaches? What is the pathophysiological basis of this? A lot of this can be worked out just from the phenotype. We know the trigeminal nerve has to be involved because of trigeminal distribution pain. We know that the parasympathetic loop, so there's a trigeminal input, and you get an output through the superior salivatory nucleus and the sphenopalatine ganglion that mediates a lot of the parasympathetic effects, such as the eye going red, watering, nose becoming blocked and runny. So we know that that must be involved. And the sympathetic side has to be involved through the sympathetic pathway through the superior cervical ganglion, going through the cavernous sinus. And it's thought that dilatation of the ICA level at this level, the anterior carotid artery, will lead to the sympathetic deficit that is seen in these patients, who often get a meiosis and ptosis to go with it. The hypothalamus comes into this because of partly the circadian rhythmicity that you see with this disorder, but also patients become very restless and agitated, and that's a very hypothalamic function. And the models that have been built even before any functional imaging work was done was something along the lines of the trigeminal input with an output that is to the parasympathetic side, and control of this loop by the posterior hypothalamus, which regulates not just this loop, but also has control over the sympathetic side. And all of the traffic, the afferent traffic, then goes through the thalamus to the somatosensory cortex. Now, can we confirm that? And this now classical functional imaging study by Anna May showed that you get the general pain neuromatrix that turns up in a lot of studies of pain, such as the anterior cingulate, insula, the prefrontal cortex, all lighting up. I'll also point out the cerebellum, because I'm going to come back to this, but the cerebellum also lit up in this. But over and above that, we saw quite specific activation of the hypothalamus in this study, very firmly putting the hypothalamus on the map for this disorder. And when you then put in all the other structures of the pain neuromatrix, you can then have a scheme that is also putting the cerebellum in the picture. And we know that the cerebellum has got connections to a lot of the structures in the pain neuromatrix, including the thalamus, the posterior hypothalamus, and the trigeminal nucleus caudalis. You also have the amygdala, prefrontal cortex, anterior cingulate, and insula, which are probably involved in all sorts of other functions, such as the affective aspects of pain. So this is what we have in terms of the neuromatrix of cluster headaches. Now, one of the things we've been interested in is to look at machine learning and what can machine learning tell us about cluster headaches. And what we did is we looked at over 708 patients who were deeply phenotyped. We had 78 specific characteristics. We looked at them, and we decided to look at, are there any clusters that actually stand out within these patients? So these maps, to sort of give you some bearing on this, is imagine that you've got 76 dimensions of data and you collapse them onto 2 dimensions. What that allows you to do is to see, are there some subgroups within this? And it clearly turns out that this purple group over here are patients who are episodic, which is distinct for those who are chronic, but also there are subgroups over here. And when we started analyzing those subgroups, we realized that those who are post-traumatic, for example, behave completely separately from the main group. people who have no autonomic symptoms are distinct from those who got remote trauma. So we decided to look at the post-traumatic group and see how do they actually differ. And what we showed and published in the JNP last year was that patients who have post-traumatic cluster headache, when compared to our primary cluster headache groups, were clearly very distinct in that they were more likely to be chronic, they had more autonomic symptoms, the vast majority of them were intractable to treatments, and they often had chronic migraine to go with it. And just goes to show that studies like these can actually start teasing apart the subphenotypes within these groupings. The other thing that we asked from our machine learning study and that we're interested in is, can we start predicting response to treatments? So verapamil is well known to be effective in cluster headaches. And we thought that, well, it'd be good to see if we can predict who is likely to be a responder to verapamil. Now, if a clinician does this, they've got no more than a 50% chance of predicting who's going to respond. However, when we did a machine learning study on the basis of all the clinical factors that we put in, we realized that from our machine learning study, we were able to show that with machine learning paradigms, you can predict who is going to respond in 70% of the patients. Yeah, and this, while it may not be good enough for clinical practice, it's a harbinger of what's going to come. I think it's just a matter of time before we start using machine learning to predict who's going to go onto what drug and what is the most likely or the most favorable drug for them to be on. The other thing that actually came out from this study was that we then looked at those people who are verapamil responders versus those who are non-verapamil responders. And what we found was that those patients who respond to verapamil had changes in the cerebellum, and the changes were seen in lobule 6, which is where you have the somatotopic representation of the face, very clearly showing that it's very likely that the cerebellum has an important gating mechanism in cluster headache, and the effect of verapamil is very likely to be through a cerebellar locus. And this just illustrates the point that I was making earlier on, that there are numerous connections between the cerebellum and the pain neuromatrix, perhaps the cerebellum is one of the structures that we need to look at in the management of headache disorders generally. The other thing that is important in the pathophysiology of cluster headache is calcitonin gene-related peptide. It co-localizes with the 5-HT1B1D receptors. Triptans suppress CGRP release. CGRP and VIP both are elevated during cluster attacks. And the elevated CGRP levels return to normal when you treat the cluster attack with oxygen or sumatriptan for that matter. And if you infuse CGRP in a patient with cluster headaches in a bout, then you can induce an attack. It's all suggesting that CGRP must play an important role in cluster headaches. And again, I'll come back to this because there are therapies based on this that are now becoming available. Okay, so let's talk about treatments. What are the treatment options we have? We generally break down treatments into acute treatments, preventive treatments, and transitional treatments. So acute treatments, as the name suggests, is to get rid of the pain. Prevention is something that generally takes a few weeks to work. And given the devastating nature of this disorder, patients often want things that will work quickly. And this is where I would introduce the concept of transitional treatments. These are treatments that don't generally work for very long, but they work quickly and often work for a few weeks and can be very, very useful in the management of the trigeminal autonomic epiphalgias. And of course, we also have neuromodulation, which can be invasive and non-invasive. So this slide over here effectively gives you all the treatments that are generally used, and everything in bold has got randomized control data for it. I'm going to canter through these now very quickly. This slide shows us the acute treatments that are used in cluster headache. The agents of choice are subcutaneous sumatriptan at 6 milligrams PRN, but I would also make you aware that the 3 milligram injection is now available, and the vast majority of patients say that it's effective and causes less side effects, and they can use up to 4 daily. So that's something to think about. And in this randomized controlled study, 3/4 of the patients were pain-free at 15 minutes. Oxygen is also effective. Almost 80% of the patients, though a significant proportion of patients get rebound attacks. Yeah, you have to give them 100% oxygen at 15 liters per minute, 12 to 15 liters per minute, which in the UK we can set up using the WHO forms. The nasal triptans are beneficial, but they're nowhere nearly as effective as subcut sumatriptan. About 50% of the patients respond at 30 minutes, so it's a longer duration to response. Though some patients do like it because it's more convenient than having an injection. My preference is always to go with the sumatriptan injections and oxygen rather than the nasal triptans. In terms of preventive treatments, the only treatment that has got any randomized controlled data from the oral drugs is verapamil. And this relatively small study showed that 12 out of the 15 patients had responded at the second week on a dose of verapamil, which was 360 milligrams daily, compared to none in the placebo group. And this slide shows what are the treatments that you can use. There's a lot of open label data that confirms that lithium, especially in chronic cluster headache, can be useful, but you often have to go up to the upper range upper part of the therapeutic range. And of course, you have to be careful in terms of the monitoring because you can get thyroid and renal dysfunction with it. Topiramate is often used at relatively high doses. I generally go up to 400 milligrams and on rare occasions up to also 800 milligrams if tolerated. Gabapentin and pregabalin are also used. Melatonin's got a very small study showing that it can be beneficial. Valproate is controversial because there's a negative trial, though it was a very poorly conducted trial. Yeah, it's, I think, safe to say that verapamil is the only one that we have good solid evidence for. All the others be used on the basis of anecdote. Now, what's new in the field is galcanezumab. Galcanezumab is a CGRP monoclonal antibody, and Lilly tried this out in episodic cluster headaches at a dose of 300 milligrams per month, which is much higher than the dose used in migraine. And what they showed was that there was a clear benefit. 71% of the patients were responders compared to a placebo response rate, which is relatively high at 53%, but not surprising in episodic cluster headache because a proportion of these patients have cycled out of the bout. So very clearly beneficial, and the risk of side effects was very low, as shown over here. 8% of the patients with galcanezumab. Didn't work in chronic cluster headaches, but I suspect that it's the trial design. I suspect that we will just need to trial the CGRP monoclonal antibodies over a 6-month period rather than a 3-month period, and the dosing regime may actually even have to be 3 weekly rather than 4 weekly. Yeah, but time will tell whether that's the case. But it doesn't seem that the CGRP monoclonal antibody is going to be particularly useful in chronic cluster headache, and not the way they've been tested out so far. Moving on to the transitional treatments, what do we have? A study recently done by a German colleague showing that oral corticosteroids, which very many of us have been using for a long period of time without any evidence base, they've now done this wonderful study, which has taken them a good 4 or 5 years to do, and they've shown that if you use prednisone at 100 milligrams once daily for 5 days and then taper the dose by 20 milligrams every 3 days and start verapamil at the same time, then in the steroid group, there was a 50% response rate compared to a 15% in the placebo group. Yeah, very clearly proving that as a transitional treatment that's effective. And similarly, for greater occipital nerve blocks, there's this study that was published by Elizabeth Leroux in Lancet Neurology now almost 10 years ago, showing that cortisol injections can be highly effective, rapidly reducing the attack frequency. We use methylprednisolone and dapomedrone and works equally well, with about 2/3 of our patients responding quite well, often within a matter of a few days. And a lot of the episodic patients essentially manage just with the greater occipital nerve blocks. For patients at home, greater occipital nerve blocks don't work. We have, on an open label basis, tried out multiple cranial nerve blocks. It is really an extension of the work on the greater occipital nerve blocks, only that we are now blocking off even the supraorbital, supratrochlear, the auriculotemporal, and the lesser occipital nerves. All of those are blocked with a combination of lidocaine and bupivacaine, whereas the greater occipital nerve block is done with lidocaine, bupivacaine, and dapomedrone. And what we were able to show in this open label study in patients who had failed to respond to a greater occipital nerve block was that 69% of the patients had a response at 2 weeks. There was an 82% improvement. Half of these patients were actually pain-free at 2 weeks. They responded very quickly. The response lasted almost 2 months, and brain freedom lasted an average of a month. Yeah, and the patient's own estimate of improvement was about 70%. There are some risks, some side effects, but they're generally very tolerable. Okay, now moving on to neuromodulation. What are the options we have over here? So in essence, the principles of neuromodulation are to target the pain neuromatrix. And your options are the vagus nerve. Why the vagus nerve? The vagus nerve has connections to the trigeminal nucleus caudalis. And that's the reason that you would target the vagus nerve. There's sphenopalatine ganglion on the basis of the trigeminal parasympathetic loop that I described earlier on, the trigeminal input with the parasympathetic output through the sphenopalatine ganglion is the reason we go there. The occipital nerve is the other one that you can target with the cervical inputs having a direct input into the trigeminal nucleus caudalis. And finally, you've got the hypothalamic region that you can also target. So let's look at the data that we have on this. For the non-invasive vagal nerve stimulation, there are the ACT studies that have been done in looking at this issue. The ACT1 study was mainly done in the USA, and the ACT2 was a European study. They looked at a large number of patients with predominantly episodic cluster headache, but some also who had chronic cluster headaches. And what they were looking at was pain relief at 15 minutes. Their primary endpoint did not reach statistical significance. But when they did a post hoc analysis, what they showed is that in the episodic group, there was a response. And what we have over here is about a third of the patients with episodic cluster headaches found this a useful treatment as an acute treatment with a placebo response rate of about 10%. But what's interesting over here is that the chronic, it was the other way around. It almost seems to have worsened it. The patients who had a vagal nerve stimulation actually did much worse. And that was in fact replicated. So this is not just some random finding because it's replicated in the ACT2 study as well. The ACT2 study reports data by the number of attacks rather than by number of patients. But I think the overall message is the same, that combining the episodic and the chronics, there's no overall benefit, but it's the episodics who benefit and the chronics who actually do worse. But the figure I would point out to you is it's 1 in 3 who find it useful. I must confess that the vast majority of my patients actually respond to subcut sumatriptan and oxygen, and using this as an acute treatment is not something that I do very often. Now, they also have some data as a preventive effect of vagal nerve stimulation, but it's all open label data. Nonetheless, what they've shown on this open label basis is that approximately about 37.8% of the patients had a 50% reduction in their headaches in a cohort of chronic cluster headaches versus 8.3% who were in fact in an open label study. So it was standard of care, but the patients who were having the stimulation clearly knew they were having it, and the control group had no stimulation at all. So it's a non-blinded study. So while this is encouraging data, what the company really need to do is they need to go and do a controlled trial to actually prove it to us. And even though this device is available, it's a paradox that we have galcanezumab, which has got controlled data, but is not licensed. But we've got a device over here for which we don't have any control data. Is far more expensive than galcanezumab, and yet we can access this. And that is despite the fact that its efficacy is actually quite a lot lower than other things that we have available. Moving on to other treatments for sphenopalatine ganglion stimulation, there is this device that a company called ATI manufactured and made available. And once it was implanted, then patients could actually stimulate the device using this remote control. And what they showed in this reasonably large study of 93 patients is that when looked at as an acute treatment, pain relief at 15 minutes, 62% of the patients could achieve pain relief. But overall, 71% of the patients reported that it was beneficial, not only as an acute, but often even as a preventive treatment. And when you break down the figures, it came down to 46% of the patients had acute relief only, 24% had both acute and preventive effect, and 49% had a preventive effect. We implanted 10 patients at Queen Square, and I must confess that this device did work very well. 8 of those 10 patients did fantastically well. Unfortunately, the company went bankrupt, though the good news is that they're about to come back onto the market very soon. And I think this is something that will start up again, hopefully very soon in the UK. With occipital nerve stimulation, we mainly have open label data. So we put together this data some time ago, and what we reported was that of the 221 cases in the literature, 61% have been reported to have at least a 50% improvement in either the frequency or the severity of the attacks, which is similar to some of the other trigeminal autonomic aphalalgias. The ICON study has been published recently. This was a Dutch study where they decided to do the study, but instead of actually having a true sham group, they in fact did an electrical dose control study. They did 30% stimulation versus 100% stimulation. Their thinking was that the likelihood is that 30% stimulation won't work and the 100% stimulation will be very effective. Yeah. Unfortunately, they were wrong in thinking that, because it turned out that the 30% stimulation itself was actually quite effective and as effective as the 100% stimulation. So having spent about 5 to 6 years doing a study, which was actually quite difficult to do, and showing quite clearly that the response rates are quite good. It's a pity because we don't still have control data for this. But nonetheless, what they did show was that the 50% responder rate was about 45%. The 30% responder rate, which leads to a significant improvement in quality of life, is 55%, which is very close to what we see on an open label basis in our very large series. And there weren't any major safety concerns. While there were some hardware issues and software issues, none of these were particularly problematic in the long term. So this is actually licensed and commissioned in the UK, but it's just a pity that we never got the data that we really wanted or would have liked out of the ICON study. And finally, we've got ventral tegmental area stimulation. So on the basis of the hypothalamic activation seen in the functional imaging studies, a number of researchers have gone into the ventral tegmental area. So it's not truly the hypothalamus, it's actually just posterior to the hypothalamus. And again, open label studies showed that there's a 77% response rate, with 42% of the patients being rendered completely pain-free and another 31% having at least a 50% improvement. So to summarize, in terms of treatments, we have established treatments such as triptans and oxygen, which is what we should offer all of our patients. For the preventive treatments, verapamil is the treatment of choice, and if the CGRP monoclonal antibodies become available, they'll be a useful option in patients with episodic cluster headaches. For transitional treatments, it'll be reasonable to offer patients greater occipital nerve blocks or corticosteroids. So be careful about the corticosteroids. Using them excessively can cause problems as well. In terms of neuromodulation, they've got evidence for using the vagal nerve stimulator in episodic cluster headaches as an acute treatment, and the SPG stimulation has got very good data. Everything else that is not in bold, we don't really have very good evidence for using, but nonetheless, those are treatments we often have to use given the devastating nature of this condition. I'll stop there. Thank you very much.
Thanks, Manjit. That was very good, and some fairly new information that has come on in the last 1 year, but particularly the genetic one and the paneling of or clusters of different types of post-traumatic and others. So we'll have a good discussion at the end. So I would ask Anish if she wants to now cover other primary headache disorders, which are thought to be uncommon, but they're not that uncommon. And if somebody is practicing headache medicine, they usually see them fairly often in a specialist headache clinic. So Anish.
Thank you, Faiz. So what I'm going to do is go through a set of other primary headaches, and I'll just start off. Oops. So we have an international classification which has 4 groups of primary headaches, and just as Faiz was saying about the prevalence, if you look, the most common is tension type headaches. So if you look at various populations, up to 87% will have tension type. And that is essentially the headache when people often say it's a normal headache. I take a couple of paracetamol, it goes away. So it's non-disabling. A prevalence of about 12% in migraine. This is the most disabling primary headache disorder. And then you get a cluster headache and related disorders, so paroxysmal hemicrania, hemicrania continua, and SUNA. So if you look at cluster headache, it's about 0.2% as a population prevalence, and then gets much more uncommon for the other 3. And this is the group of primary headaches I'm going to talk about. The main ones I'm going to talk about is the top 4, because these are ones you're likely to see. And the one I'm going to concentrate on is thunderclap headache, because despite the fact that the data that we have, it is not particularly well managed. and the information about how we should manage is not passed through. So I think this is something particularly if you see people acutely. Prevalence-wise, although this is always thought to be uncommon, they're not, and you'll see, and I think the reason is they're paroxysmal, they're short-lived, they're paroxysmal, they occur in bouts, and these bouts tend to be self-limiting, and they're not like cluster where you get them again and again. So the prevalence is relatively high in comparison to cluster-related disorders, but you don't see them as often. So I'm going to start off with thunderclap headache. So thunderclap headache, so this is the current international classification. So this is your sudden onset explosive headache at the back of the head. So the classification here is reaching maximum intensity from within a minute, lasting for less than 5 minutes. And what I'll go through is why actually this isn't correct. It should actually, this will get about 75% of your thunderclaps. What you really want is a much higher proportion. And if you increase it to increasing in 5 minutes, you'd get 95%. So this is the data that I want to go through. So the population prevalence, there's one study, is 43 per 100,000 person years, of which 38 per 100,000 person years is primary and not secondary. The secondary headaches, the main one that we talk about is subarachnoid hemorrhage, and that's because historically, the case fatality has been up to 66%. This has got better by about 70%, 17% per year. And that's been down to the fact that we diagnose it more quickly, investigations done, and they're treated much more rapidly. So again, going through this escalation within 1 minute, what I'll go through is show you why the 1 minute is not enough for you to get all of these primary and secondary thunderclap headaches. So the whole issue is, how do you know that a headache is primary or secondary? So we know for the majority of headaches, it's not about the isolated headache syndrome, it's the additional features. But thunderclap is the one where thunderclap in isolation has a very high prevalence of a secondary precipitant. So what we have here is 85% have in subarachnoid, it's aneurysmal, and 10% are perimesencephalic. And what that means is that largely it's probably venous, it's much more benign. You do an angiogram and you won't find an aneurysm. You'll have 5%, which is other disorders such as an AVM. And what you'll see is about 14% of people with thunderclap headache will have so-called sentinel headache, which means that if you ask them in the 2 weeks or before, they will have had the same headache, which has happened several times prior to the one with which they come into hospital. So this gives you an idea about the 1 minute to the 5 minutes. So this looks at your aneurysmal subarachnoid, your perimesencephalic, and your primary thunderclap headache. So the first is a description as a burst, a sudden burst. So you can see it's not much difference across the three. If you have a look at the mode of onset, instantaneous. So primary thunderclap headache, 68%, less in those with subarachnoid. But to some extent, you know, you really need the subarachnoid to be almost zero for this to be useful. 2 to 60 seconds. So here again, you cannot differentiate a primary from a secondary. As you go up 1 to 5 minutes, again, you can't differentiate. As we get to over 5 minutes, you now start seeing, yes, they're fewer, but over 5 minutes, you're much safer, making the assumption that this is likely to be a benign thunderclap or not thunderclap at all. If we compare them, so the age is around the same. So this is your sentinel. This is your sentinel headache. In both primary and subarachnoid thunderclap headache, they've all had a past history of thunderclap beforehand. As we know with primary and secondary headaches in general, the severity doesn't help you, but it's often what prompts the treatment. You get a precipitating event in primary and secondary, and these are exactly the same precipitating events. So what you have here is sexual headache, straining on the toilet, lifting, again, that's Valsalva, and then different types of exertion. So diving, swimming, exertion that precipitates a thunderclap headache. So often when you have somebody presented with exertional headache, and the query is, should I scan this patient? It's really talking about this thunderclap headache group. And again, there's no way you can differentiate even here on neurological symptoms. Hard signs is something different, but you're only going to get hard signs in a subarachnoid is when you get parenchymal involvement or you get a blockage of the CSF space. Again, that has to go through the parenchyma eventually to block that pathway. So if you look at the additional features, seizure, so remember that 50% of what comes to your neurologist as a seizure is normally not a seizure. And then again, the focal neurological symptoms, not the signs, is what we're talking about. So the bottom line, if it's thunderclap headache, you're not going to differentiate it's primary or secondary. You are going to have to investigate more. So this is the classical investigation. And so it's a CT within 6 hours. Now this gets you probably, on average, this will get you 98.5. So the 99.4 is a 3rd generation CT with a neuroradiologist. So that's sensitive for subarachnoid hemorrhage. But even then, that's only 1.5% who will have a normal scan. The question then is, what do you do with that group? If it's beyond that, it drops off significantly. So it'll drop off after 6 hours to about 87%. Then you will have to do a CSF examination. So CSF, the blood in the CSF starts to convert about 4 hours. So some emergency departments, to get people out, will just do the CSF at 4 hours, but you may get a false negative. So you need it at 12 hours up to 2 weeks, and it's 100% positive. So if you have somebody who has thunderclap at 1 week, you're much better off just get your CT, do a CSF, because you'll know if they've bled or not. If you do an angiogram, all that will tell you is that they have an aneurysm. We know 2% of the population have an aneurysm. You're then stuck with the patient knowing they've got one and not knowing what's going to happen, and then the screening and how people screen for these. What we know more now, particularly look at familial barianeurysms, is that actually screening probably isn't enough, because the ones that develop rapidly and they'll burst outside any sensible screening time. So xanthochromia in the CT negative, so that 1.5%, so has slightly varied, is 0.4 to 7%. So what you're looking at is, let's say the worst case scenario, 7% of 3% originally who had a normal CT in 6 hours. The reassuring aspect of this is that most of these are venous, and most of these, the long-term outcome is good and you don't find an aneurysm. So what a lot of A&E departments are doing now is if they have a CT within 6 hours, which is normal, they'll discharge you. If your CSF is normal, within that 2 weeks, then your diagnosis is primary thunderclap headache. Even if the headache is persisting, it's more severe, that is your diagnosis. They don't need an angiogram, because then you're back again to a whole scenario of an incidental aneurysm. And this is the data for that group. So this is the group of individuals. If you look at the N number, these were CT negative, CSF negative. And the mean follow-up, so what we have is here 3.3 years, 1.75. So the maximum we have is 5 years. And again, this is your sentinel headache, so recurrent thunderclap headache and previous thunderclap headache in this group. Subsequent headaches or any type of headache, again, a high proportion. Prior headache, a high proportion. And this is again a combination of tension type headache and migraine. This is looking at your thunderclap headache, which is all causes. So cerebrovascular is your biggest group, so that will get your subarachnoids, but thunderclap headache can present with other precipitating pathologies. The large proportion is idiopathic. So this non-specified headache is just looking at papers where a neurologist made a diagnosis, and admittedly a lot of these papers will be old, but it's slightly mortifying that, this is a neurology diagnosis of non-specific headache. Primary headache, again, is a large proportion. And then smaller, we have infection, unknown, non-neurovascular. In those where they had a CT angiogram or an MRA, and there was vasoconstriction shown, this was 2, 3, 4. This is outside this other group who didn't have any sort of angiography. And this gives you an idea of the different pathologies within these different groups. So cerebrovascular, you have aneurysm, dissection, hemorrhage, infarct, venous sinus thrombosis, so it's a wide range. Infection can be systemic, maybe CNS, but we always have sinusitis, but that's presumptive. That's your presumptive diagnosis. So remember, any secondary diagnosis is presumptive, and the basis is that it's temporally related to the pathology to make it much more likely that it's precipitated. So if you look at vasoconstriction, a large proportion just have this thunderclap headache, but again, a complete mix of different pathologies that can precipitate it. So again, the bottom line, any pathology can precipitate it. You have to investigate all of them. And when you have a look at the different causes, most of these you'll get on a good history, general and neurological examination, the CT and the CSF. So this will pick up your cerebrovascular, largely pick these up. Your systemic, it will pick up. Vasoconstriction, again, the history will give your drugs, but all of this you will pick up in those investigations. The ones in the non-neurovascular group, so the pituitary apoplexy is one that you do need to keep in mind. They normally are sick, but not invariably. We have CSF pressure disorders, neoplasm, intracranial air, chemical meningitis, neuroinflammatory, and psychiatric, which I think, again, whether it was or isn't, again, it's presumptive. So a whole different range of pathologies. So this is the group of idiopathic, and sudden onset. So you have your primary thunderclap, but here again, when I went back to your thunderclap precipitated by cough, sexual headache, exertion, we have sexual activity, and this curious phenomenon of bath-related headache, which is seen usually with a hot bath or with people pouring water over themselves, generally hot water. Primary exertional headache, exertional sexual activity, weightlifters, that's probably a combination of exertional and Valsalva, and then again exertional and sexual headaches. So you're back to this group of syndromes, but these are thunderclap in onset, and these are the ones that you are going to investigate, but a large proportion of these will be primary. So in summary, with your thunderclap headache, ideally, although it's maximum intensity within a minute, lasting less than 5 minutes, it's not. It's within 5 minutes, it can last a long time. So we know people with thunderclap onset, new daily persistent headache goes on for years, doesn't mean there's a secondary pathology that's persisting. You can't differentiate primary from secondary. All of them should have a CT within 6 hours, more than 6 hours, CSF, and if they have additional features in the history examination, then you may need additional investigations. So remember, with your CSF, you'll pick up infection. If the pressure is raised, you'll pick up pressure problem, or you'll pick up a venous sinus thrombosis on that. And your systemic will pick up everything else. And always remember your press and your high blood pressure. Sentinel headache isn't helpful, and it doesn't tell you anything about what has happened. The bottom line with sentinel headache is, if it's thunderclap, it doesn't matter when it is, it needs to be investigated if it's for the first time. And then, reversible vasoconstriction syndrome, it is a radiological phenomenon. So that is all it is at this point in time. So then I'm going to go to cough headache. So this is headache brought on by any sort of Valsalva, and maneuvers lasting between a second to 2 hours. And I'll go through where that's come from. So this is what I was talking about, the fact that, despite the fact this has a much higher prevalence, which we'll see about 1% with all of these compared to cluster, because they occur in self-limiting bouts, often you'll see them and then, they're gone after several months, and they don't come back again. They might come back, but they're not problematic in the majority of the longer term. So you have a look at the age group. So it's the over 50 age group generally. You can see different characteristics, but the important one is the explosive one every time. Different sorts of Valsalva, so weightlifting, laughing, straining at stool. And if you look here, these are short, so they're generally minutes to 30 minutes. They can be up to 2 hours. Laterality doesn't really help you. They can be bilateral, but they can be unilateral. And again, the frequency will develop and be based on what's causing the cough at the time and whether the disorder is active at that time. And then duration. So this is what I was talking about. This is months, so 18 to 36 months in this study. The duration, again, a couple of years here, 3-4 years here, 2 years in the Chen study, which was the largest study. So these tend to be largely self-limiting. They may have features after the actual cough has precipitated pain. So you may get the typically migrainous features, or you may have no features. So the secondary headache is the one I want to go through. And this is really coming down to Chiari to some extent. This is a really lovely paper. So it's 1956 when you're allowed to write reams and reams about what you'd seen and what you'd observed. And there is a tendency for posterior fossa lesions. But if you have a look at these, 1, 2, 3, 4, 5, 6 patients, 3 had isolated cough headache. This patient with meningioma had radiotherapy and surgery. The cough headache settled, but this second one, the headache didn't start until 2 months post-op. If they'd had the scan beforehand, you would attribute, or many would attribute the acoustic neuroma with the headache. Didn't have any treatment, spontaneous resolution at 1 year after respiratory infection. This is the natural history of these disorders. This patient with a midbrain cyst, so this is the risk. This is the risk of surgery in these areas is death. There's always that risk of death. Paget's disease, we don't see very much of this. So in these patients, again, isolated headache. In one patient, we have signs. So again, look at this resolution after an air encephalogram. This one, a 10-year history after a flu-like illness, and then has a 4-year natural remission. So be very careful if you're attributing something to a secondary, as a secondary precipitant, if you're going to do something invasive, because the natural history is these get better. And if somebody has surgery, apart from the placebo surgery, is often attributed to the procedure. This is a comparison. Again, you have your idiopathic, and here we have mainly Chiari. So remember, Chiari, not an acquired Chiari. This is a childhood disorder with or without syrinx. Natural history in the majority, including if they have a syrinx, is that they tend to improve. The syrinx can go either way, but it can spontaneously improve. So the examination here largely normal. In those with a syrinx, it gradually became abnormal. Again, the duration can be similar in primary and secondary. And what we find with these paroxysmal disorders, that they respond well to indomethacin. So a lot of paroxysmal disorders, indomethacin seems to be the most frequently documented successful treatment. So in this group, the prognosis, again, self-limiting in the benign group, more persistent in the symptomatic group. This is one of the largest studies, a total of 83, out of which 9 had an abnormal scan. So here we have posterior fossa meningioma and hydrocephalus. Only one has had an abnormal examination, so ataxia, limb and gait ataxia. We have 2 posterior metastatic deposits. Chiari, it varies in different papers, with a 3 to 5 millimeters. Again, sinusitis completely presumptive. Again, I think the subdural is probably presumptive as well. It's just you find an abnormal scan, you really have to think, is it related to what the patient has? And often it's not. So always remember, the incidental rate of finding something on a scan is 6% to 10% on average, much higher as you get older. What is very helpful here in this study is that almost 40% of the secondary responded to indomethacin. So if you think it's secondary, as you know, the acoustic neuroma case, it came after the surgery. If they respond to indomethacin, there's no need for a surgical intervention, which has greater risks. And then again, the remission, and this one also, as you can see, the ones with the Chiari actually had intermittent symptoms. Again, this is like the natural history. So In summary, this has a 1% prevalence. Again, as I showed you, 5th to 6th decade, brought on by Valsalva. The seconds to 2 hours will get most of them, as you saw in the cohorts. The precipitated headache can be with features or without. You can't differentiate primary from secondary, but surgery should really only be for progressive neurology, not the isolated headache. Then I'm going to go on to exertional headache. So this is brought on by and occurring during or immediately after strenuous exercise. And the definition here is 48 hours, and I'll show you where that comes from. So these are the different sorts of exertion. Although the exertion has been thought to be much more strenuous, so we have your skiing competitions, heavy exercise, but if you come down here, we have routine homework. So must be some sort of autonomic phenomenon. So I suppose it depends on your activity and how hard that activity is for you. And this is where we get our definition from. So again, these are much larger groups that we've seen here. This is a much younger age group. This was the Chen study was a pediatric, so 500 cases. The character, they can have migrainous features once the headache is precipitated, but they may have none. Again, few minutes, up to a couple of days. So that's why we have the 48 hours. And then you can have multiple in a day over several years. So here we have a 10-year history in the first study, mean duration 4 months in the third. We don't have the duration in the last study. Again, laterality, not particularly helpful, tend to be bilateral, but can be unilateral. But what is interesting is the comorbid other primary headaches. So if you look at migraine, this is higher than the population prevalence of migraine. If you look at sexual headache, cough headache, Valsalva headache, these tend to often occur together in the same individual. And this is a study looking at the two primary and secondary exercise headache. So what we have is the age range is not too dissimilar. Minutes to days, the secondary was a bit longer. We don't have the frequency for the secondary. So again, this will depend on the frequency of the exercise. And again, it's days, months, or years that these can last. Again, laterality doesn't help you. And it's the explosive thunderclap, which is the secondary, which is important. They may have additional features. And again, the secondary can have any sort of pathology, because this is the same pathology as your thunderclap group. So the prevalence here varies across different publications. 1 to 26% suggests a female preponderance. Again, secondary cases, exertion precipitated thunderclap headache. And then we have this curiosity, which is cardiac aphasia. So this is a patient whose ECG is at 30 minutes after they had a headache. And what you see here is in the anterior leads, you see the takeoff, which is rather high. And then at 2 hours, the takeoff has dropped again. So what you have here, so again, the atrolateral leads, you can see in the lateral leads, you've got the T-wave inversion. So this is a headache which occurs with exertion, can occur with emotional exertion, can occur with sexual activity, and it's a manifestation of cardiac ischemia. So the syndrome you can get, as with the others, can be with or without features. They don't always have chest pain, arm pain, dyspnea, palpitations, may just be the headache. Tends to be an older age group with cardiac risk factors. The diagnosis is with the cardiac investigation. So the majority will have an abnormal ECG or 24-hour ECG. Some may not, but what would be useful is the response to GTN. So individuals who have cardiac risk, if they take GTN, it gets better. Whereas classically in these disorders with studies in migraine, tension type cluster, if you give something like GTN, it precipitates the headache. So you need to have slightly higher threshold with people who have risk factors and have a look at the additional symptoms. This responds to treatment of the coronary stenosis, so always worth keeping in mind. So finally, I'm going to go through headache with sexual activity. There are two types. So there's one where it increases with sexual excitement and at climax just settles. Then you have the second one, which is your thunderclap, just before or at orgasm. Again, it lasts from minutes to hours. Severe intensity may last longer. And this is the group you have to investigate. To date, I've not seen a case report of the gradual onset being reported with a secondary precipitant. It's normally the thunderclap. And here you can see this is the S in the onset is the sudden, G is the gradual, generally featureless. And once again, it's the duration, they're short, so they can be minutes, generally to hours. So here again, they often have remission for years. Here in the second study, 6 weeks to 6 months, days to months. The next one, 2 days to 18 months. What's interesting that 82% have a single bout and less have more than one bout, which is probably why we don't see this very much. And again, what you see here is the comorbid headache disorders, much higher than the population prevalence. And with sexual headache, there are case reports, one in a mother and daughter, and then one in 4 siblings who all had sexual headache. So the more you see of all these disorders, of all those 4 groups, these all are likely primary headache disorders with a genetic predisposition. It's just that one with the ones with the lower prevalence, is going to be much harder to get the patient groups to get the genetic results for this. So this is the treatment responses. So again, can be throbbing, can be bilateral, but again, indomethacin. But the other one that seems to come up quite frequently is beta blockers. So nadolol, propranolol have been shown to be effective. So primary headache associated with sexual activity, you have the gradual onset increasing with sexual excitement and then settling. The one that you need to investigate is the thunderclap onset. Again, we get this 1% prevalence, this familial occurrence, and the secondaries are all thunderclap. And finally, just going to go to treatment responses. So the most frequently reported is indomethacin. So here in each group, you can see others where there are anecdotal reports or a number of reports. But again, you can see here some other non-steroidals, or the COX-1, COX-2 can be tried. And then the second most commonly reported are the beta blockers. What's quite interesting is a number of reports of use of a triptan. And what you, so that can be used to treat the headache afterwards if it's more than a couple of hours, but you can use it preemptively. So again, with indomethacin, or let's say propranolol, what you could say is if you're going to exercise, you know, there'd be trial and error 40 minutes before, excuse me, take 50 milligrams of indomethacin and then see if you can do your exercise without precipitating the headache. Then they can titrate it up. And you can do exactly the same with the triptan. So before they're about to exercise, before sexual activity, then you can use it preemptively. Obviously, you have to be very organized. And if that doesn't work, then the indomethacin or the other non-steroidal or beta blocker, those would be the first 3 to go for use as a standard prophylactic. So in summary, these are paroxysmal, either spontaneous or precipitated primary headaches. The highest risk factor of an isolated headache is thunderclap, whether it's precipitated by cough, Valsalva, exertion, sexual activity, or spontaneous, largely indomethacin responsive. It's self-limiting, often in single bouts, can co-occur, and any secondary precipitant must be for the neurology and not this isolated headache. Thank you.
Thank you very much, Anish, and I'm really sorry. The problem with chairing a webinar is you can't offer water to the speaker.
That's all right.
Got some water.
I should have some here.
That was very nice, and I think good literature review of all the rare primary other primary headache disorder. Just one thing before I start asking the question, could people put their question on a chat line rather than raising their hands, please? So if you put it on the chat, then I'll take it turn by turn. So Anish, the most common primary other primary headache disorder that I see is ischemic or primary stabbing headache.
Yeah. So I didn't go through that because I think that needs more time than to do it all together. Again, it's indomethacin sensitive, largely, or beta blockers.
Or amitriptyline?
Yes, again, lots of anecdotal responses. I've seen ones responded to pyramate. Yes, amitriptyline. Yes.
Yeah, I know it's just for our audience that this is quite common that people come and say, I felt as somebody burst in my head, but it went away within a few seconds.
Yes, so exactly. Very different to Thunderclap.
Just a few words on nummular headache. I think.
Yeah, I didn't put the nummular hit in it because I sometimes think the more you give, the less people remember. So, so nummular headache is just a coin-size headache. It's literally, and often you don't really ask patients, but they'll say, "Oh, it's just here." But if you ask, it would be like a 50p piece. And again, I've not got many, but quite a few of those have responded to indomethacin as well. Yes.
Manjit, just to think about multiple cranial nerve blocks. I mean, I never use that. I always give them a gone injection. How does these multiple cranial nerve blocks work in cluster?
Yeah, so the mechanism of action is, I think, quite interesting that, we don't really have a good handle on how any of these nerve blocks work, yeah? Not only in just headache disorders, but actually across the board, yeah? That when you look at what is used in the nerve blocks, it's local anesthetic and steroids. And when you ask the question of how long are these around, not for very long. They're out of the system very quickly, even if the steroids persist, yeah? Suddenly the local anesthetic effect wears off very quickly. And yet across the board, when you look at how long you get a beneficial effect from these, yeah, not only in headache disorders, but also in other pain disorders, that effect can be days or weeks, very often weeks, yeah. So there must be some sort of a wind down phenomena that goes on that we don't really understand very well. So we did a functional imaging study looking at this, trying to understand this, yeah. But in the main, what we found was that some of the neuromatrix is wound down, but there was nothing specific we managed to find just from the nerve block as to what could be the cause of this, yeah. But it's a very interesting and important question. I think the other thing that's worth laboring is that in cluster headache, it's the steroids that are really important, yeah. But in migraine, it is actually the local anesthetic that matters. And the number of studies that are coming through is showing just that if you leave the steroids out in cluster headache, they don't do very well. If you leave the local anesthetic out in migraine, they don't do very well.
The other thing which was very interesting was the involvement of cerebellum.
Yeah.
An intermediate area from the brainstem right up to the peripheral, like trigeminal nerve.
Yeah. Yeah, so I think it's gating a lot of the information that's coming through, yeah. And I must confess that we didn't go looking for it. We were a bit surprised by it. We thought that we were going to find something else, yeah. We were more expecting to find some other structure involved in the direct pain neuromatrix if we were going to find anything. And just goes to show the power of these, these studies that they can actually, with large numbers, with machine learning and with the data mining that you can do, you can suddenly pick up things that you simply weren't aware of. And clearly that fell out, yeah, that there was a somatotopic representation. So this was not just some random finding that, it was exactly where the cerebellum would be expected to be involved, because somatotopic representation is pretty much of that part of the head, which is where the majority of the patients have cluster headaches. And the minute you start putting the literature out, you suddenly then find that actually there are loads of connections, yeah, between the hypothalamus and the cerebellum, the PHG and the hypothalamus, even the somatosensory cortex has got indirect connections. And then we've got the trigeminal nucleus caudalis also involved. And there's a lot of crosstalk going on. So our view is that it's very likely that verapamil is mediating its effect through the cerebellum somehow, and that is then having an implication, that having an effect on the rest of the neuromatrix. And actually begs the question that is there something further we can do? Other on animal work, you're trying to understand what is going on at that level, and can we manipulate it in some other way? Are there some other chemicals involved, yeah, or other signaling mechanisms involved that we can manipulate? Or the other options to think in terms of, is this going to be a target for some sort of neuromodulation or neurostimulation, indirect neurostimulation? And I think all of those are open to discussion. Yeah, it's things to explore and think about.
Manjit, it is very interesting that the gamma core,
yeah,
Tanezumab, they both show response in episodic but not chronic cluster headache.
Yeah.
There is one single thing that you could think of that makes episodic respond better than chronic?
Yeah, so I mean, this may simply be an issue in terms of a severity issue, no more than that, yeah? That, we have got a disorder that is far worse on the one hand, but I'm not sure it's just that as an explanation, because what I then find puzzling is, why would episodic cluster headache actually improve in at least a proportion of the patients with gamma core, but actually the chronic ones worsen in terms of an acute effect? Yeah, you may not actually pick a response up, but to actually see a response going in the opposite direction is very puzzling. Yeah, and same thing for the CGRP monoclonal antibodies. Yeah, that it's a bit disappointing that we didn't see the CGRP monoclonal antibodies doing anything significant in the chronic cluster headache cases for both framinizumab and galcanezumab. Yeah, but we see an effect in the episodic group, at least with galcanezumab. Now, over there, I think there is some data that has been abstracted rather than actually published here, where what they have shown with galcanezumab is that when you look at what is happening in the 3rd week in patients with chronic cluster headache, there's a significant reduction, but by the 4th week, it has reversed. Yeah, and if you just look at, the curves, you end up thinking that, well, actually, if they'd repeated the galcanezumab on a 3-weekly basis, perhaps it would have had a response here. So there's that issue, but there's also the issue in terms of the open label experience that is coming through from a number of centers is that in chronic cluster headache, the CGRP monoclonal antibodies are more effective at the 6-month time point. And so it may be just that the time we need for them to be on board is much, much longer. But the question that, this comes down to, are we looking at the same disorder, but just a more severe variant, hence the reason that we're not getting a response? Or is there something that is actually distinctly different between them? Yeah. In our machine learning study, they clearly, sort of fell apart on the other sides, but they were part of the same circle. Yeah, it didn't come out as though they're completely separate disorders. The phenotype wasn't separate. A lot of the other symptoms that we had here, a lot of the other things that we had, such as response to treatments, yeah, all lay on a gradient. So there wasn't anything that was saying to us that these are different disorders. So I think the gamma core data in that respect is a little bit surprising that, in one group, you've got a worsening of the symptoms rather than no effect at all.
So do you think that this could be a cumulative effect, that you have to carry on with the CGRP mAb for quite a long time before you actually see the
Yeah, so I think I think it's probably going to be 2 things. And I think the Lundbeck people are starting to look into this. Yeah, they're doing an open label study in cluster headache, and I think the essential point is going to be: do we give higher doses for a longer period of time, and see if we can get a response? Yeah.
And the other thing that came in my mind is if the vagal nerve, puts a response in episodic but not chronic, could it be possible that episodic have got more vagal nerve involvement in the pathophysiology compared to the chronic ones?
Yeah, I mean, that's a possibility, or whatever the pathway is, yeah. Assuming that we truly know the pathway, yeah. I mean, as a lot of the work done by Anna May has tried to outline what the pathways may be, and those are reasonably well defined. Again, there's nothing that actually stands out in terms of what could be different, but really it has to be something that is going on in these people that is different.
Okay. Anish, there is a question from Anthony Thomas in Coventry. Well, you already answered that you haven't tried diltiazem.
Yes, I haven't tried it. What I found normally is the indomethacin, propranolol, abstinence, and then it just gets better. So you very rarely see the sex headaches come back over and over. The cough headaches sometimes do, but they just are very self-limiting. I haven't tried a calcium channel.
Okay. The other question I had for you, Anish, was how many thunderclaps would you allow before you say, oh, I'm not going to investigate?
Yeah, so I think this is difficult because I had this discussion recently. So, for example, in certain places like in Ireland, they don't have, and some hospitals don't have the facility to do the CT-CSF, so they do an angiogram. And if you have the angiogram, then you know if you don't have an aneurysm, you don't know if it's bled or not. So what I tend to do is if you've done it once and it's recurrent, then once is fine, the CT-CSF, and then you leave it because this is likely to be self-limiting and it'll get better. Now, if they come back 3-4 years later, it may be their second bout, but you don't know. I'd investigate it again.
So I'll give you an example. A patient comes to me and says, for the last 3 months, every time I have a sexual intercourse, I get a thunderclap.
Yeah, okay.
Like twice a week for the last 3 months.
Yes. So on that basis, that's very difficult. I would probably investigate them. The question is, what do you investigate them with? And the reason for that is based on all of that data that says that whether you have primary or secondary, both groups have had a number of thunderclaps before that, so you can't predict it. So ideally, what I would do is say, if you have one, you have to come and have CT and CSF. You have to do that. They obviously don't like that. Then the easy way out is to say, okay, I'll do a CTA. That leaves you in a problem if you find something. So I think you still have to investigate it based upon the evidence that exists.
Because if this patient would have come to me and said twice a week, last 3 months, I would probably dismiss it. I wouldn't.
No, I know. I mean, I think that's what mostly, but the problem is if you look at all the groups, they all have a prior history, whether it's primary or secondary. They've had thunderclaps before and they have thunderclaps after. So as long as you've done it once, then you're all right.
Right. So you have to do once.
Well, it's not a case you have to do. Yeah, I think, I suppose the way to look at it is, let's say, you know, the probability is this patient isn't going to have a subarachnoid, because subarachnoid is quite rare anyway. It's dramatic, but it's rare. But if they did have one, if you went back to the clinical evidence, it would say, well, what about this sentinel hemorrhage? Okay, it doesn't exist, but we know they do get thunderclap before, and that doesn't help you say it's a primary or a secondary. So I think if you...
Why people get sentinel headache? Because I know when the aneurysm rupture, you get a headache, you know why is
yes.
That? Why would people get sentinel headache?
It's probably trait. I think it's trait.
All right. Okay. What are your views, Manjit, about recurrent thunderclap headache over a period of a few months? Would you investigate?
Yeah, I would agree with what Nish is saying. I think it's challenging about what to do. And I think damned if you do and damned if you don't, yeah? But my view would be very similar to what Anish is saying. So
do investigate them.
Yeah.
And obviously, if it's a 3-month history, the best thing is the CT angiogram or MR angiogram?
CT is where I would go.
No, there's evidence for CTA compared to MRA. So if you ask the radiologist, you will miss some on the MRA compared to CTA. So I think MRAs are gone nowadays. We don't use them anymore for angiograms. Even venograms, we use the CTV. Because on the MRVs, you get a lot of, you get a bit more noise.
Now, if somebody has a positive lumbar puncture, then obviously you do a conventional angiogram. You wouldn't do a CT angiogram.
I don't know. I think they do a CTA. I think the CTAs are really good. I think the proportion of proper conventional angiogram, I don't know, because normally once they've got the aneurysm, they're off, and we don't really, you know. So I don't know the answer to that, but I think the CTA might give you enough.
No, but if they have got a xanthochromia, you do a CT angiogram, you find an aneurysm, then you still have to do a conventional angiogram anyway.
I don't know. I don't know if that is enough for you to do whatever you want to do, to coil it.
Yeah.
If that's enough for you to coil it, because when you coil it, you're going to do the angiogram anyway, aren't you?
Yeah. Our neurosurgeons say positive lumbar puncture, conventional angiogram. Negative lumbar puncture, good history, traumatic lumbar puncture, CT angiogram.
Yeah, no, you don't need it. So if your CT,
traumatic lumbar puncture.
Traumatic lumbar. The problem with traumatic lumbar puncture is you can tell, because if you have a traumatic lumbar puncture, you won't get the bilirubin, because the bilirubin, that's why you wait for 12 hours. If you do a CSF at 12 hours, whatever's traumatic hasn't had time to give you bilirubin. So what you will get, so the problem is, if you had a traumatic tap, they couldn't do anything about it. 4 hours have gone, then you're in trouble. But within that 4 hours, you could do another one and you'll still get xanthochromia, which is positive. But most of the time, by the time you found out it's a useless sample, your 4 hours are gone, and then you have to do CTA then.
And the other thing I don't agree with you respectfully, Anish, CT scan normal, don't do a lumbar puncture within first 6 hours.
No, I do it. So what I'm expressing to you is, so there's a big group of A&E physicians. So there's an Ottawa cohort study that they've got all these risk factors. And so what all the A&E teams want to do is they want to just get them out. So what they're saying is that the risk is so small that this is adequate. Now, as a neurologist, the neurologist will always say, no, you need to do the CSF. Now, at Whipps Cross, they were very naughty, because the way they got around it is said to the patient, this is your risk of having an aneurysm or hemorrhage. Do you want to have it or don't you? We advise you do. If you don't, you just sign this form. So that's the way you can get out of it, but they should do it.
I know the risk is very small, but that one case would finish.
So that is exactly the point that, you know, as a neurologist you would make, is that you miss that one, even in 10 years, that's going to cost you more than all those admissions that you get in here. So it's not worth it. So I would always say, do the CSF. But this is the A&E consultants who often don't do it.
Yeah, they want people to
yes, they want them out.
Some even do a lumbar puncture within 2 to 3 hours and get them
yes
out.
So that's what I was saying. They were saying, okay, we just do it at 4 hours, you know. Yes, that's right.
Manjit, this subcut immigrant and people getting 3 to 4 attacks a day, and they are allowed to have 2 injections. A lot of GPs moan about it.
Yeah.
Is there any message you want to give, if there are a few GPs on the audience, that this is nice guidance that they can have use up to 2 injections and 4 or 3 milligrams?
Yeah. So NICE is very clear about this. Yeah. So when we wrote the guidelines, one of the things that we actually made sure that we state very clearly in the guideline. And so the guideline very clearly states that subcut sumatriptan can be used twice daily for the duration of the bout, if needed. And so the nasal triptans can be used up to 3 times daily. Okay. And I generally just write back to GPs, because with the large cohort of patients we look after, you'll get the occasional GP who will say they're not going to do it. And generally what we do is we just write back to the general practitioner and say, see, this is what the NICE guidance says. Yeah, this is what the disability is from this disorder. Yeah, and we'll just be grateful if you could prescribe it. In the main, I find that, most of them will comply. Most of them are simply not aware. The message that has often been passed to them is that, oh, we shouldn't be prescribing acute treatments. They often have the migraine mindset. And when you actually point out to them that actually cluster headache is different and this is legitimate, my general experience has been actually very positive, that the vast majority will say they're willing to do it. There'll be the occasional one who'll dig their heels in. And then I just have to get the practice manager involved and just say to them, see, this is the guidance. I can't see any good reason not to do it here. On one occasion, I had to prescribe it myself from our hospital, but that's, one out of, currently I've got about 800 plus cluster headache patients under my care. So it just goes to show that I think with the NICE guidance, it has really, really helped. The thing that I'm getting a bit of pushback from now is using the 3 milligram. Yeah, a lot of my patients prefer the 3 milligrams. They get less of the asthenia, and it seems to, in the vast majority, work just as well. So I've said to some of them, see, just move over to 3 milligrams. And if they're only having 2 attacks a day, it's not a problem. The issue tends to be when they're having 3 or 4 attacks a day. Yeah. So the nice guidance says 2 a day is fine. Yeah. The view I take is that, well, if 12 milligrams is fine, then 3 milligrams times 4 is fine. And I'll try and get that. Again, I find that the majority of the patients, it's fine. And often
it's a cost issue, basically. So the issue is, it's normally they're fine, it's just expensive. But in fact, if somebody's having 3 to 4 a day, they shouldn't be just using the injection. And the problem with the 3 milligrams is it costs the same as the 6 milligram. Yeah. And there is RCT, so there's RCT data. In fact, the 2 milligrams does better than the 3 milligrams, even in side effect profile and preference. But the problem is it costs, so they...
We're aware of the cost. I mean, it's besides the cost, the bottom line is that they're going to be patients who are going to be going through a bad phase. Of course, we are going to put preventive treatments on board. And of course, the message always has to be that if you've got a high frequency of attacks, you need to crack on with the preventive treatments. But the reality is that the preventive treatments often don't work. We often have a group of patients in whom we are trying to titrate things. They've got a few weeks before they're going to be better. And under those kind of circumstances, you can either leave them untreated, and if they've got devastating attacks, I've got patients having 2 or 3 hour long attacks. That twice a day, 6 hours knocked out of awful pain versus the cost, which while I appreciate it's a lot, I generally find that if you make the case to the GPs, most of the people are reasonable. Yeah, and it's just a matter of education.
The problem comes with chronic cluster headache patient getting 3 to 4 attacks a day every day for months.
Yeah.
GP says, 120 injections he's used in 6 weeks, and I mean, he's the only patient using about 30% of my budget. And
yeah. I mean, as much as I fully understand that, but the bottom line is, this is what the patients love to have. It's safe, and we just have to be advocates for them as best as we can be. But I think Anish's point is absolutely very well made, because the other worry always is that people get stuck with just doing the acute treatment and forgetting the preventive stuff, and we mustn't. We must keep on pushing on the preventive stuff here and being quite proactive about that to try and reduce the intake of the acute treatments as much as we can.
Octreotide. Octreotide injections.
Yeah, so we did the study. There was clearly an effect. There is clearly a logical basis for why it should work. We know its mechanism of action will be through a CGRP mediated pathway. Yeah, the difficulties in clinical practice is next to impossible to do. The injections they have are not the easiest ones to do, but can be done. But again, funding, it's even more expensive than sumatriptan.
We have a mutual patient who uses about 20 injections of octreotide a day.
No, I know there are. Because we had this interest in the pituitary disorders, we inherited a few patients. Yeah, so I've got about a dozen patients who not only use it for cluster headaches, but also cluster headache-like syndrome, but also for migraine. And of course, they're hugely expensive. I think in standard practice, because it's not part of any guideline, it is simply next to impossible to do. And I must confess, I don't even bother going down that route anymore, because the response generally is no. But does it work? I think it works, but only in a small cohort of people. I don't think it's like sumatriptan oxygen, where a large number of people respond. It is a relatively small group of people, but those who respond, they do very well. It's just very difficult to sustain in the long term without the evidence base to back it up.
Be worried if they use 10, 12, 15 injections a day.
I don't ever do this on my own. I always get an endocrinologist involved. The main thing they look out for is the gallbladder, because these patients become very prone to getting gallstones. And I'll let them do all the monitoring. In fact, the endocrinologist is always involved, because all of these patients have got a pituitary disorder, at least the ones I'm looking after. Yeah. So that's the context in which I do it. I don't use octreotide as much as I would love to. I simply don't use it in primary variants of cluster headache, simply because I can't. Yeah.
Anish, I know you are not a big fan of RCVS.
No.
Talk about it. Why you are not a big fan of it?
It's not a fan. It's, what used to be called Call Fleming, I think, wasn't it? Yeah. So it's a radiological phenomenon, and most people will admit that. So if you ask most people, that is all it is. Look at the evidence, that is all it is. So the problem is it provides a dustbin diagnosis for people not to think. So that's a problem. And I think probably, I mean, it arose from, from headache. It came from headache. And I think part of that came from the perspective that actually what you normally see in headache is a vasodilatation. So now you're seeing vasoconstriction. There must be something associated with this. So I would never just attribute something to that radiological phenomenon. You would have to look and make sure there's nothing secondary, the normal way, and then that's it really.
Would you agree that recurrent thunderclap headache, one of the diagnoses is RCVS?
It's not a diagnosis, it's just a radiological observation that you get, because the problem is what you don't do is you don't do angiography on all of them. And what you have to do is not just at the time, you have to do it sequentially. And so you see different patterns of vasoconstriction in different people, lasting longer, going off. So it's not just at the time of the thunderclap.
No, but we got quite a few patients whose repeat angiogram gone back to normal. So they do have reversible vasoconstriction. They
do, but what I'm saying is that if you look at the cohorts where they've actually done the angiograms longitudinally, sometimes they have, sometimes they haven't, sometimes it comes back. So it's a question about what you do with it. And I think you don't treat the vasoconstriction, because some people say, oh, I put steroids, I do this. If the person is well, you don't do anything.
Yeah, but this is reversible vasoconstriction that has causing recurrent thunderclap headache.
Well, is it? That's the question, isn't it? Is it causing it? Because you get a whole load of them that have no vasoconstriction. So what's causing that?
Correct.
Mm-hmm.
Agree with you. Last question, Manjit. 100 milligram prednisolone a day. I've never used that kind of a dose. I do 60.
Yeah, that's, I mean, I must, it's I think German, it's reflective of German practice. Yeah. So a lot of the Germans traditionally have given 80 milligrams a day. And in this particular study, they decided to go with 100 milligrams. Yeah. I must confess that it's good to have that evidence base, but I still start with 60. I do 60 and then go down in steps of 10. I generally do it over a 3-week period rather than the 2 weeks that they did. Yeah. But I think the principles are the same. I find that the vast majority of the patients are going to respond at 60. I don't think 100 actually adds much more than giving them more side effects, but that's my personal view. So I think it's reasonable to stick to 60.
I've used 60 for the last 25, 30 years. I've never gone above. I mean, if the data would have come from Americans, then I would have agreed that they are overweight and 1 milligram per kilogram. Germans are not overweight.
Yeah. And can I just pick on one thing? I think Michael Gross has asked about how long after head or brain injury would you give attribution to the onset of cluster headache? Yeah. So the ICHD is very clear about that, and we stuck to the definition. Yeah. So Michael, we stuck to the 1 week. It used to be 2 weeks. They decided to tighten up the criteria, and they've gone with 1 week. And in our study, we stuck to 1 week as well. So again, it's the same old question. Yeah. At what point do you attribute something that's going on within the brain? Yeah. There can be prolonged changes that take a little bit of time to come through. Yeah. The animal data points towards that whatever changes are going to take place very likely take place very quickly. Yeah. But I'm not sure that's what we see. We certainly see a lot of people who will have some sort of a head injury who, 2 or 3 weeks later will end up getting headaches. But then begs the question that if you're very loose about that definition on a medical legal front, it becomes very difficult. So I think the lawyers have defined this more than the clinicians. But I think for the time being, we have to stick with the 1 week, which I think is a reasonable time point.
Another thing just came in my mind, Manjit, about, I've probably forgotten now. Anish, and I'll come back to you, Manjit. The question I had for you was, you said hot water would cause you a thunderclap. I thought it would have been cold water.
I know you would. You think with ice cream headache. But if you look through, this is one of the 30, it was more than 30 sort of bath headache. It was mainly hot water. So either getting in or the water being poured over, more commonly hot.
I get it with the cold water.
Do you?
Yeah. And you probably thunderclap, yeah.
Gosh,
ooh, just comes suddenly. So one thing is there was a program in Channel 5 that many people would have mentioned to you. They recommend swimming in cold water. Do you find
apparently improves migraine, I'm told, yeah. Well, it's just an exercise phenomenon. Actually, the swimming, who knows? Yeah.
Yeah. A lot of people now come and say, oh, after watching that program, they started to swim in cold water, but they end up getting a headache.
But this bath headache is really interesting. Yeah. I have never seen a bath headache in the UK, despite looking for it. Yeah. But on my trips to India, whenever I've been with Ravi and the others in the clinics, yeah, certainly see them. Yeah. And people give very good stories about how they, so it makes you wonder whether there's, and when you look at the large series, they mainly come from India, makes you wonder whether there's some sort of a genetic basis on which, they're getting them. Yeah, whatever that phenomena is, it's something that, seems to happen, and you come across it more often over there. Yeah.
One final question. Would you scan everybody with cluster headache, even if they have a 15, 20-year history?
No, I think once you pass the first year, yeah, it's highly unlikely you're going to pick up anything abnormal. Do we scan them? We scan them mainly because patients want a scan. Yeah, and I don't think it breaks the bank because the number of people that are going to come along are very small. But besides the first cluster bout, yeah, I have got next to zero pickup in anything abnormal. I, in fact, spend more time having to talk them through the pituitary abnormalities and all the other, epiphenomena, other, incidental things that you pick up. And I think it's just more challenging having to deal with them. But if you don't do the scan, all of these people are convinced that they've got something nasty going on, and your hand is forced. I must confess that I'm in that lucky position that by the time they come to me, the vast majority have been scanned. But nonetheless, I think beyond the first part, it's not my practice to push for it.
And one last thing for you, Anish, if you don't mind me asking. You give beta blocker for sexual headache, then they can't get an erection.
Exactly.
What do you do?
No, so I give them indomethacin normally, but I do say you can have a beta blocker, but that might sort the problem out completely. So I do warn them. So give them the options for their GP, what they want to try. Otherwise, yeah, exactly.
You told me that you have treated my headache. I said, how? He said, I now can't get an erection.
That's right.
You're not having sexual headache. Well, thank you very much, Anish. That was really good. And thanks, Manjit. And thanks for your valuable time. And it was really nice talking to you on the webinar. Sorry, I couldn't offer you a glass of water. And thanks all the attendees. And thanks for the whole year of webinar series. And we'll come back to you sometime next year. Thank you very much.
Thanks for organizing them, Fayez. Thank you.
Bye.